My name is Clive Rosendorff, and I'm a professor of medicine in cardiology at the Mount Sinai School of Medicine in New York City, and I also work at the Bronx VA hospital. My particular interest is in cardiovascular pharmacology and perhaps more particularly in hypertension. The question that I'm going to be addressing at this meeting is really a universal and important one. And that is, when one is dealing with patients with high blood pressure, how low should the blood pressure be lowered? This seems a simple question. It has enormous implications. And everybody who treats patients must be aware that this is, in fact, one of the most important things that you need to think about when you're treating high blood pressure. Now, the magic numbers that have been given up to now are 140, 90, that systolic should be lowered below 140 and the diastolic below 90 millimeters of mercury. There is nothing magical about these numbers. If you think about it, a patient with a systolic blood pressure of 138 will live forever, and a patient with a systolic blood pressure of 142 might have a stroke the following day. It doesn't make any sense. There is, in fact, a graded risk, and the higher the blood pressure, the greater the risk. And the corollary of that is that the lower the blood pressure, the lower the risk. Okay, now given that, you might say, well then what's to stop us from lowering blood pressure down to below 130 or below 120 or below 110 systolic? Well, the limiting factor is, of course, blood flow. The arterial pressure drives blood flow through vital organs. Now, the critical organ that we're talking about here is the myocardium, because the filling pressure of the myocardium is the diastolic blood pressure. The myocardium is perfused only or primarily during diastole. So we should concentrate on the diastolic pressure. Now, the question therefore boils down to a very simple one. What is the lowest diastolic pressure that you can get down to without beginning to impair myocardial perfusion? And the answer is that we don't have an answer. There are really no good data to tell us what that number is. We have to rely on epidemiologic evidence, and we have to rely on animal studies, and we have to rely on a number of clinical studies, none of which really were prospective studies which asked that particular question, how low to go. They were all retrospective analyses of existing clinical trials. For what it's worth, the epidemiologic evidence tells us that the risk for coronary artery disease and cardiovascular events decreases all the way down to a systolic pressure of about 110 or 112 and a diastolic blood pressure of 60 something. So that's very reassuring. The animal data also are reassuring, but of course these are animals that don't have coronary artery disease, they're not exercising, and besides it's very difficult to extrapolate from those data to humans. The human clinical trials data is conflicting. Some of them have shown that there is, in fact, a lower limit of blood pressure below which the incidence of coronary events starts to rise again. And that's called the J point, or the J inflection. As you know, if you lower blood pressure, systolic or diastolic, cardiovascular events decrease. But of course, if you get too low, it's obvious that those cardiovascular events will start. There'll be an uptick and they'll start going up again. What is the level of the nadir of this J curve? Well, it varies from one study to another. And most people have found that it's somewhere between 120 and 130 millimeters of mercury. Now, the ACCRD study, ACCRD, was designed to answer this very question. This was a study in diabetic patients in which they were randomized into two groups. The one group in which the blood pressure, the target was less than 140/90, and the other group in which the target was less than 120/80. And you can see that's quite a big difference. And ACCRD was enormously successful in actually achieving a big delta value, a big difference between those two groups in terms of blood pressure. The systolic blood pressures did vary by, or were different by about 16 millimeters of mercury. The ACCRD data showed that there in fact was no advantage, that there was no benefit in lowering blood pressure below 120 over 80 compared to 140 over 90. At least that was the conclusion of the ACCRD investigators. But if you look at the data very carefully, you can see that at the lower blood pressures, there was actually a lower incidence of myocardial infarction and MI deaths and cardiovascular events, although that did not reach statistical significance. So from the point of view of coronary events, it seems that the lower blood pressure was reasonably safe. What was also important in terms of the data was that at the lower blood pressures, there was actual protection from stroke. And in fact, the incidence of stroke was statistically significantly lower in the lower blood pressure group than in the standard blood pressure group. I must say, however, that the incidence of stroke was very low in this study, and a lot of people have kind of fobbed this off. So this is in accord with a lot of other data from the clinical literature to show that lower blood pressures do protect from stroke, but the data for coronary events is really equivocal. Where does that leave us in terms of our recommendations? Well, and since you can't treat coronary artery disease in isolation from stroke, we will obviously have to put stroke prevention into the equation.